Thibault, thank you very much, and good morning. I like to talk about this topic because it's a good example of the need to individualize care. We know, is it working or not? Can the translators hear me? Should I do something?
Yes, sir.
Beta-blocking agents, of course, are agents that can decrease heart rate and the force of contraction of the heart. Intensive care doctors like me are a bit hesitant sometimes to prescribe it because we are very concerned about the oxygen delivery to the tissue, and we want to have a sufficient cardiac output to bring enough flow to the organs. So if we think about the various therapeutic options to increase oxygen delivery to the tissues, of course, there is no place for beta-blocking agents. Once we have optimized oxygen content of the blood, we can only give the fluids, transfusions, or the glutamine as a beta-stimulating agent to increase oxygen delivery to the tissue, and nitrates in normotensive patients. But usually when there is a question of oxygen delivery, the blood pressure does not allow to give vasodilating agents. So when we have to treat a problem of inadequate oxygen supply, we may use noradrenaline to restore vascular tone and increase arterial pressure, but then we go for a beta-stimulating agent, dobutamine, to increase cardiac output. There is no place any longer for dopamine. This is out. It's associated with a higher mortality rate in shock states, probably because of the tachycardia. And there is hardly any place for adrenaline, except in very severe cases when we are close to cardiac arrest. So with the Surviving Sepsis campaign, we suggest using a beta-stimulating agent, dobutamine, in patients who show evidence of persistent hypoperfusion despite adequate fluid loading and vasopressor agents. This could be supported by a measurement of SVO2 or central venous oxygen saturation through a central venous catheter. If the SCVO2 is low, it is a further indication that we need to do something to bring more oxygen to the cells. Again, it could be fluids, transfusions, or dobutamine. You may say that early goal-directed therapy doesn't work. There are 3 studies showing no improvement in survival rates, but these patients started with a SCVO2 of 70 to 73%. Thank you very much. So then, how can you increase it further? When it's already normal, there is nothing to correct. Whereas in the previous famous study by Rivers and collaborators, the SCVO2 was 49% at the very beginning. So my colleague, Daniel Debacker, and I wrote this piece where we say, you know, these are different patient populations. We are not looking at the same thing. And we further wrote this paper that will appear next month in Chest, where we suggest to start with generous fluid administration and noradrenaline to correct profound hypotension. But then later, in a later stage, we could check SpVO2, and if it's low, it would be an argument to give a beta-stimulating agent. Now, what those? If we go back to this very old study on a pure beta-stimulating agent, isoprel, on the toxin shock, we can see that with isoprel, the death rate was significantly reduced with isoprel, suggesting that bringing more oxygen to the cells would be helpful. However, with higher doses, it was worse. So we are speaking about small doses of beta-stimulating agent. And that's how we recommend when we use dobutamine in patients who are not in severe heart failure, that we use only a few micrograms per kilogram per minute, 2-3 micrograms per kilogram per minute. As there is a risk when we stimulate the heart, there is a risk of myocardial damage. This is a often cited study which is on patients with septic shock, looking at the heart at autopsy and finding the presence of necrosis and mononuclear cell infiltrates in these patients who died from septic shock. Yes, indeed, when we compare dopamine to noradrenaline in circulatory shock, as we did some years ago now, we found that dopamine was associated with a higher mortality rate, especially in cardiogenic shock, but there were more arrhythmias with dopamine than with noradrenaline. So there is a risk when we use beta-stimulating agents. And there are a couple of studies showing that the routine use of the dobutamine can be associated with a worse outcome. Dr. Felahi published it 10 years ago in patients submitted to cardiac surgery. The use of dobutamine was associated with major cardiac morbidity, more arrhythmias, more myocardial infarction. And this is another study from Finland showing that in septic shock, the use of dobutamine may be associated with worse outcomes. These are just two studies, but it shows the risks with any drug. There is a risk. Tachycardia, increased cardiac work, reduced diastolic filling time associated with the tachycardia. And it's not only for the heart, it is also for the periphery. We know that beta-adrenergic stimulation can increase the catabolic state of the tissues and induce hyperglycemia, hypercoagulability, and may alter the immune response of the patient. So, with this in mind, should we go in the other direction? What about beta blockade in severe heart failure, in cardiogenic shock, in septic shock? What is the place for beta blocking agents? Well, first, let's consider the hemodynamic effect once again. This is the most fundamental equation in hemodynamics. Blood pressure is determined by blood flow, and the arterial tone. If we stimulate, let's say with ibuprofen or dobutamine, there will be an increase in cardiac output and a fall in vascular resistance, right? Beta-stimulating agents decrease vascular tone. The blood pressure may go up a little bit as a result. Well, if we go for beta-blocking agents, we use it in the management of chronic heart failure precisely to put the heart at rest or to treat hypertension, right? Because by this mechanism, blood pressure could decrease. So, we need to have this equation in mind at all times. But it's also in the periphery that it matters. And there is a fundamental study by Dr. Hendon in burn patients a number of years ago, showing that giving beta-blocking agents in stable patients with burns, the heart rate would go down, the oxygen demand would go down, and actually there may be an increased net muscle protein balance. So the patients may be stronger if we avoid the catabolic effects of beta stimulation. Now, there are some studies showing also that beta-blocking agents could improve the metabolism of septic animals. Okay? It makes sense. But again, this is in stable conditions. And this is with propranolol. Propranolol, as we know, blocks all beta-adrenergic receptors. Should we block more the beta-1 receptors or the beta-2 receptors? Well, there are some studies suggesting that beta-2 stimulation may be counterproductive. Although in passing, I must refer to this study in animals showing that the animals that do not have the beta-2 receptors have a worse myocardium at autopsy. So, beta-2 stimulation may not be that bad. However, if we are concerned about heart rate, contractility, then we should go for beta antagonism with atenolol, bisoprolol, esmolol, metoprolol. And a lower heart rate, again, can increase the diastolic time and may therefore increase stroke volume to some extent. So we would have a reduction in heart rate and an increase in stroke volume associated with a better cardiac failure. So in animals, there are some studies showing that beta-1 blocking substances may actually provide some cardioprotection and perhaps improve outcomes. This is a study from Australia, from Nalomo and co-workers, showing again improved cardiovascular and renal function and circulating cytokines in hyperdynamic sepsis. It's not really a model of shock, it's more a model of sepsis. But it's all a matter of doses. Of course, if we give too much beta blockade, it could be bad. And that's exactly what we did in our laboratory with esmolol in these experiments on our sheep model of peritonitis. It's a very relevant animal model, large animal. We can monitor many things. And the message is never published that because we thought it was actually low. But the message is that with small doses, there may be an increase in stroke volume and the preservation of cardiac output, but with higher doses, cardiac output goes down, blood pressure goes down, and Jan-Lui dies. So we must be very, very careful with this type of intervention. Now, okay, let's move to use. And it's interesting to look at the history of shock therapy. When initially people were focusing in the 60s on vascular tone, angiotensin, which is back today, as we know, or nevaterol, or metarabinos, which is still available in Australia. I don't know in Russia. And almost at the same time, people were interested in increasing the force of contraction of the heart with isoprel. And then came the idea that we could combine the two, perhaps with dopamine. It's quite interesting to see how it evolved. But already in 1966, in the New England Journal of Medicine, people spoke about isoprel. But at the same time, or just a few years later, Dr. Boeuf suggested a role for beta blockade in the treatment of septic shock. Yin and yang. Very interesting. And this is a paper from 1972, where Boeuf described actually some increase in blood pressure. Because if you block the vasodilating effect of beta stimulation, you could have an increase in vascular tone. So it's quite interesting to see that there may be, problems of myocardial stunning also with the use of excessive doses of adrenaline, and in the field of cardiopulmonary resuscitation, this is also a timely topic. But interestingly, I was involved in a study published many years ago, in 1987, in the Lancet, where we showed that in patients with severe head injury, who have tachycardia, which is quite common in these conditions, the use of beta-blocking agents could potentially protect the myocardium with a decrease in the release of cardiac enzymes. At that time, it was the CKMB. It was not the troponin yet. So that suggested that beta-blocking agents could protect the heart in this acute stressful condition. So again, yin and yang. Beta stimulation to increase oxygen delivery. This will result in a higher SpO2. Beta blockade, you could decrease oxygen delivery, decrease SpO2, and induce some degree of vasoconstriction. Will induce some degree of vasoconstriction. So, what about the perioperative optimization? We have seen many studies starting in the last century suggesting an improvement in the postoperative course of patients submitted to major surgery. So the study by Holdermans, published in 1999, was very eloquent, right? Showing that that patients treated with beta-blocking agents could have a lower mortality rate. Aha! Interesting! Wow! No. Dr. Holdermans, the paper was retracted, was fired from the Erasmus University in Rotterdam, and so the story started Dr. Lindenauer did a very nice study a few years later, showing that there may be a protective effect of beta-blocking agents in patients with major comorbidities, in patients with hypertension, plus heart failure, plus coronary artery disease. Yes, these patients could benefit, but those with limited comorbidities could be harmed by beta-blocking agents. And indeed, then came some other studies showing what we could expect. With beta-blocking agents, there may be more bradycardia and hypotension. Of course, that's what we can anticipate from beta-blocking agents. And this has been shown in a number of studies here in diabetic patients submitted to non-cardiac surgery. The Boyd study was very important, published 10 years ago. It showed perhaps a little bit of an improvement in terms of myocardial infarction with metoprolol, but somewhat more deaths and more strokes from hypertension, bradycardia. And so the analysis showed that patients with sepsis would be harmed with the patients who received the beta-blocking agent. So that's how we can today put the things together, saying that there is a horizontal in hemodynamically unstable patients and moderate that benefit in stable patients. This is with acute myocardial infarction. So there is an increased incidence of bradycardia hypertension. We need to weigh pros and cons of beta-blocking therapy. I like this paper very much because it's a meta-analysis of randomized controlled trials of beta-blockade to prevent perioperative death in non-cardiac surgery. It was published 5 years ago, but there is really not many new studies on this since then. And they wrote a very strong conclusion. Guidelines bodies should retract their recommendation. This should not be blocked by dispute over allocation or blame. There is an increase in mortality when you give beta-blockade routinely in the perioperative period. And actually, that's where we have been in the last year. But interestingly, a Swedish group, which has a large registry of colorectal cancer, just published this paper showing that globally the patients who were on beta-blockade prior to surgery had less deaths of cardiovascular or respiratory origin and less postoperative infection. And actually they published even more recently, I think this is still in press, a paper showing the same thing in emergency colonic cancer surgery. The same information, two different journals. But putting everything together, as in this very nice editorial in the British Journal of Anesthesia very recently, the message is that if there are major comorbidities in stable patients submitted to surgery, we may consider the administration of beta-blocking agents, but not in patients without major comorbidities. Again, there are potential benefits to protect the heart, there are potential risks of cardiac hypertension, stroke, and renal failure associated with low cardiac output. Now, in sepsis, also it seems that previous prescription of beta-blocking agents could be associated with a lower mortality. Well, we don't know when we can develop sepsis. We know when we are submitted to elective surgery, but we don't know when we will develop sepsis. Now, okay, maybe there can be a reduction in blood lactate level, but we know that this is primarily a metabolic factor. This study made a lot of noise. Dr. Morelli and collaborators published in the JAMA a small study of patients that they called with septic shock who received esmolol versus placebo. And there was a reduction in mortality. It was 80% in the clinical room. Wow! What kind of patients is this? They were not so sick. Their lactate levels were not very high. So we have questions about the type of patients they enrolled and the overall management of these patients. We wrote this letter, but others did the same. So, and now they published this, well, no, there is another paper that came out suggesting that there is also a decreased mortality in these patients. Now, you may not read Chinese papers, but this paper, I don't either, but this paper shows that esmolol could improve cardiac function and myocardial compliance and reduce the myocardial injury in patients with septic shock. These were stable patients. But I think the idea is very interesting. And this is a nice study, published in the Chinese journal, but I think it makes the point very well. That with beta-blocking agents, they say in septic shock, these patients were not in septic shock. They had a lactate level of 1.4 milliequivalent per liter, speaking about septic shock in interval 2, right? So, but the heart rate went down, and actually cardiac output went down, but not to the same extent, because there was a little bit of an increase in stroke volume. Oh, why? Well, precisely because the slower heart rate allows a better filling of the ventricles. Ventricles have more time to fill. And this is a relatively large study, and I think about 65 patients. So it is quite interesting, because they could identify, they say, the patients who may benefit via a simple echocardiographic assessment showing a good myocardial function. So in patients with sepsis and tachycardia and a good cardiac function, there may be a place for beta-blocking agents. Not when they are in severe shock. So, beta-blocking agents in sepsis? Yes? No? Well, we can say a word about alternatives. If you think that dobutamine may be harmful, maybe we could try levosimendan, which, as we know, is an inotropic agent that will increase the interaction between calcium and the myofibrils. I don't know why these authors did that study. They gave levosimendan routinely in patients with sepsis. Of course it's bad. You do not need to give inotropic agents to everybody. I don't need inotropic agents. So, of course, they had more organ dysfunction and a somewhat higher mortality. Why would you give an inotropic agent to everybody? If you like to read a meta-analysis on this, there is no place for levosimendan administered routinely in these patients. Okay, now, perhaps we could decrease heart rate via another agent, which is ivabradine. Ivabradine is a high-path inhibitor. You may know it. It's a substance that may reduce heart rate without decreasing cardiac output. I think that's potentially interesting. In our animal laboratory, looking at pigs with septic shock with Dr. Epstein, we could show, as you can see here, a substantial reduction in heart rate without change in arterial pressure. without change in Caldacott, without change in SpO2. So that could be very interesting. And there are now some studies starting on this in patients with septic shock. Now don't ask more from ivabradine. This is a very good study published recently from the group in Nancy, in France, showing that there is no impact on blood pressure, as I say, but there is also no impact on cytokine levels. So we should not use it for anything else than to reduce heart rate. Although, in this recent paper in anesthesiology, ivabradine could improve the microcirculation. That's interesting. And there were some previous data in particular conditions showing that ivabradine may protect you on the pill. So that's something that we may consider. I have no conflict of interest whatsoever for this presentation. So let's finish up by asking them what is the place for beta-blocking agents. Well, we would think of tachycardia as a good indicator of excessive beta-adrenergic stimulation. But it's very important to see why the patient has tachycardia. Because if there is a decrease in stroke volume due to myocardial compression, hypovolemia, or pulmonary embolism or tamponade, these are the three causes of the low cardiac output, we should not give the beta-blocking agent. But if stroke volume is increased with a high cardiac output, perhaps not associated with anemia or hypoxemia, but associated with sepsis, inflammation, stress, hyperthyroidism, we need to think about it. So we need to separate, in a way, the cardiac events and the peripheral events. For the heart, I would love to give the beta-blockade to protect the myocardium, especially in elderly patients with coronary artery disease. Less tachycardia, less cardiac work. But I want the organs to be happy. And if the patient is in a post-operative state, or post-traumatic state, or sepsis, the normal pattern is a high cardiac output associated with a high SpO2. And if the patient is stable, it's okay. But if the patient is unstable, we need to think twice before we give a beta-blocking agent. Again, I have shown the slide. Think at this yin and yang. With the beta stimulation, there may be unwanted cardiac effects, but there may be unwanted peripheral effect with beta blockade if there is a reduction in oxygen delivery to the organs. So we can think at the number of positive effects, favorable effects of beta stimulation, and the number of positive effects with beta blockade. So the nice thing about our field is that we should not look at the camera, we should look at the fire, but we can apply the MIA rules that are already presented yesterday. We can measure, interpret the flow. When we give a beta-blocking agent intravenously, exactly as when we can give the glutamine intravenously, we can check the effect, measure it, and then we interpret and apply. So I showed you this slide. I would not give a beta-blocking agent if tachycardia is compensating for a low stroke volume. I would not give a beta-blocking agent if there is tachycardia associated with anemia or hypoxemia. I would not give a beta-blocking agent if it's associated with vasoactive medication. I would rather decrease this medication. I would only give it in some cases of inflammation, anxiety, stress, perhaps So we need to think, we need to individualize our strategies. Is the patient is on vasopressor therapy? If it's yes, I would not consider beta-blocking agent. Are there signs of altered tissue perfusion? If it's yes, I would not use beta-blocking agent. Is it a hyperkinetic state? It's only if the answer is yes that I will consider a beta-blocking agent, especially in the presence of coronary artery disease. Again, we need to individualize our therapy. Giving a beta-blocking agent to all patients with tachycardia, that would be terrible, terrible, very poor medicine. We need to go through this assessment to select the right case for the right medication. Thank you very much.